I know we are in storm mode here in Louisville. I am very, very excited and happy to introduce Dr. Krishnamoorthy. I know that many of you all remember Sam. She was a resident here from 2014 to 2016 and is just awesome and great. She did her nephrology fellowship at WashU, went out into private practice for a few years, and went back to do her transplant fellowship at WashU. And so presently she is an assistant professor at the University of Chicago. So part of my master plan is to get everybody excited about nephrology. You see the results of someone who, did the rotation at Jewish Hospital, did transplant there, and now she's a transplant nephrologist. Sam is going to be talking to us about living kidney donation, the opportunities and challenges. And thank you so much for, giving this talk, Sam, and I'm so happy to see you, even virtually. Happy to see you.
Thank you so much, Dr. Yusuf. And I did my first nephrology rotation with you. So definitely that's brought me here today. So everybody in nephrology played a big part in like inspiring me and wanting me to be a nephrologist as well. So thank you to everyone that I trained with in medicine and in nephrology at UofL. So it's so nice to be back. So I wanted to start by giving sort of the background of kidney disease in the US as to why living kidney donation is important. So we have about 500,000 patients on dialysis per USRDS 2018 data, about 80,000 waiting on the wait list, of whom about 22,000 got transplanted, of whom about 6,500 were living kidney donation transplants. So clearly there is a large gap in the care that we can provide. There are still many patients waiting on the wait list for kidney transplants. And increasing our living donation numbers is one of the ways we can bridge that gap, given the shortage of deceased donor organs. In addition to that, living donation also sort of eliminates the wait time for a patient. So they're not waiting for 5, 6, 7, 8 years for a kidney transplant. So depending on what your blood type is, if you are a B or a O, you would be waiting a lot longer than someone who's AB. And then the gray zone is the number of deaths, and green is the proportion of patients who are taken off of the wait list because they have a medical complication and they are not candidates anymore. My apologies, I'm not sure. There we go. So if at year one, this proportion is much smaller, but by the time they're on the wait list for 5 years, you can see that a good proportion of the patients fall off the wait list. And living donation can again give them an opportunity to get a kidney before they have complications and suffer from the mortality from being on dialysis. But most importantly, the indisputable reason why living kidney donation is the gold standard treatment for end-stage kidney disease is that it offers the best long-term survival. So on the left are the two boxes represent living donor, the right is deceased donor. The top two boxes are patient survival and the bottom two boxes are graft survival. And you can see that the slope, comparing the slope of Kaplan-Meier survival curves of living and deceased donor, living donors do much better in terms of graft survival and patient survival. And this study actually broke down these patients into cohorts of about 5 years or so. And you can see that our survival rates are actually improving with time, showing that we're doing the therapy, our diagnostic techniques are improving with time, and we're actually able to show an improvement in long-term survival as our transplant field has moved forward. So I'm going to break down my talk into 3 parts. One is, which is personally very fascinating for me, is the evolution and the history of living kidney transplantation. Then it sort of flows into what are the current challenges of assessing donor risk. And then the third part is a little bit of a breakaway where I will discuss one of the topics that I'm currently working on, which is how we can make evaluation of living donors with nephrolithiasis better. So that's going to be a little bit of moving away from part 1 and 2. So what happened in 1800s was basically, I didn't even want to know because it was a lot of crazy experimentation, a lot of tissues that were tried to be grafted from animals into humans, from humans into humans, skin, bone, teeth, blood, to really kind of try and understand whether a tissue is even viable outside the body. And of course, these were sort of field experiments, and they happened all over the world. And eventually, what was interesting is that organ transplantation only took off when you had the surgical technique to join two blood vessels together. So it was really vascular surgery that first had to be, the technique had to be developed for vascular surgery, which then eventually led to solid organ transplantation in the 1900s. And at the same time, parallelly, there had to be an immunological revolution to sort of understand the immune system better, which eventually sort of both developed into leading to development of what we know as transplant today. And again, coming back a full circle, we obviously started from xenografts and we're back to xenografts. So the last couple of months have been very exciting, where UAB transplanted a gene-edited pig kidney into brain-dead human. NYU Langone did the same thing, and University of Maryland actually recently, last month, did the first historic porcine heart, genetically modified pig heart, into an adult human who was otherwise not a candidate for heart transplantation as a last resort. So we're still waiting to find out what happens with the University of Maryland patient. So going back to what was actually the first kidney transplant, that technique-wise, so surgical technique, actually, the first person to sort of finalize that was Yuri Voronoi, who was in Soviet Union in 1933. He had a 26-year-old female patient who committed suicide by consuming mercury, which was popular back in the day. And she had acute kidney injury because of the mercury. And eventually what happened was there was a 60-year-old deceased kidney. There was a 60-year-old deceased patient that they took the kidney from, and it was actually placed in the thigh into the femoral vasculature, and the ureter was brought out. So that kidney never worked, apart from the fact that it did perfuse. So from a vascular technique standpoint, it was a success. There was ureteric peristalsis, and it made a few drops of urine, about like 5 cc urine, and the recipient died 2 days later. But apart from that, there was really, this was like the first deceased donor kidney transplantation to sort of surgically have success. So, and then World War II spurred really development of skin grafting because of injuries during the World War, burns and blasts, that research in skin grafting really took off. Around this time, also, cortisone was finally isolated from the adrenal cortex. So we sort of start seeing this movement in immunosuppression as well. So there was successful skin grafting from one identical twin to another in St. Louis. And then the right side is Dr. Medawar, who eventually went on to win the Nobel Prize in 1960 for his work in acquired immunity. And he really discovered immunological tolerance and the concept of acquired immunity, that the first graft lasted longer than the second graft, which was rejected even faster. So he's really the one who spurred the field of transplant immunology. So the first living kidney transplantation, we know about the HERRICK twins, but the first one to happen was actually in France by Hamburger et al. There were different groups in Paris at that time working on kidney transplantation. And in 1953, the Maurice Renard, who's in the picture on the left, was a 16-year-old carpenter who fell down from the scaffolding and injured his solitary kidney, which had to be removed. And then the surgeons realized he didn't have another kidney. And so basically, there was no dialysis at that time. And his mother came forward and agreed to be the donor for his kidney, and living kidney transplantation was performed. That kidney actually lasted for 22 days. At about 22 days, it stopped making urine and the patient became uremic, and the recipient died. But that was the first instance when a living kidney transplantation was successful for 20. Of course, know about Joseph Murray and the HERRICK twins. So in Boston in 1954, we had the historic identical twins, Ronald HERRICK, who donated his kidney to his twin brother. And then by 1976, the Boston team had actually performed transplants on 29 pairs of twins. That's Dr. John Merrill and Joseph Murray on the right. John Merrill was the nephrologist and Murray was the surgeon. So I'll sort of talk about how surgical techniques have also evolved. So initially, we used to do open nephrectomy, which was a very painful procedure for the donor. And this has now evolved into laparoscopic procedures. Again, this is the position in which usually the donor is laid, and most commonly the left kidney is what is approached during surgery for nephrectomy. And then another common technique is now we use is hand-assisted laparoscopy, where basically the hand port is used by the surgeon to deliver the kidney out from that end. So we also now have minimally invasive single port surgery that we just started doing at University of Chicago, where there's a single port in the belly button through which you basically do the whole surgery, and the patient just wakes up. The donor wakes up with basically a Band-Aid over their belly button. And funnily, this actually happened to one of our donors who got woken up after anesthesia, and he asked the nurse whether something had happened and the surgery got canceled because he couldn't see anything on his belly. And he was worried that the surgery got called off. And then we had to explain to him, like, remember, this was minimally invasive surgery. So that's it. That's the scar you're going to have over your belly button. And so he didn't even realize that that's how small it was going to be. And then lastly, we have robotic assisted kidney transplant, kidney nephrectomy for donors, which is again less scars for the donor, faster recovery. So from open nephrectomy, we've really moved on to developing newer and better surgical techniques, which really make the recipient also feel much more reassured that the donor is not going to suffer as a part of this surgery. I'm just going to exit. I think my timings are playing into this from a previous session, so I'm going to play it again. So then Dr. Starzl eventually spurred the sort of evolution of immunosuppression and immune therapy for kidney transplantation and for organ transplantation. So he is the father of modern transplantation, and in the 60s, he introduced the azathioprine and steroid combination therapy from the outset of transplantation to improve graft survival, and he also pioneered the first liver transplant surgery. This is a common slide in transplant nephrology where we talk about what really has sort of how much we have traveled from the early 1950s and 1960s now to 2020s, where during this time, the improvement in immunosuppression really has spurred the graft survival to go from 30% to over 90%, to what now we call ourselves as victims of our own success. So the big breaking point was 1960s when AZA and steroids came into play. And then eventually in 1980s, again, Starzl showed the use of cyclosporin and tacrolimus. So calcineurin inhibitors really changed the game and improved the allograft and patient survivals. And in addition to that, induction therapy with thymoglobulin, basiliximab, and then introduction of mTOR inhibitors, sirolimus, everolimus. So now we have more medications in our arsenal to take care of our kidney transplantation patients, most recently belatacept, that we've also started using. So interestingly, but you can see from 1980s, a big jump in how many living donors, living kidney donations that were done, leading to successful kidney transplants. But it peaked in 2004 and then took actually a dip and then keep going up. It's sort of unclear why exactly this happened to pinpoint to one reason, but it is attributed to a combination of allocation policies where around this time, pediatric patients were given more preference on the deceased donor list. So maybe less living kidney donations going to pediatric patients, and the onset of recession around this time, which again points to the fact that financial barriers are real when it comes to living kidney donation, and that probably were a couple of the reasons that explain why that dip happened. So 2000s to now, we have had a lot more engagement and encouragement to push for living kidney donations. The organ procurement transplant network policies have been put in place for standardizing evaluation of living kidney donors. We have policies in place for follow-up of living kidney donors up to 2 years after donation and making sure that the transplant programs comply with that. Establishment of National Living Donor Assistance Center in 2007, the National Kidney Registry in 2008, which spurred paired kidney donations. Programs like Independent Living Donor Advocacy, Living Donor Champion programs, and then both OPTN and the American Society of Transplant have dedicated living donor committees and work groups that address issues affecting our living kidney donation programs. And then most recently, we all know the Advancing American Kidney Health Initiative that had one of the main goals was to increase access to transplantation, and living kidney donation is one of the ways to do that. So thankfully, we're starting to see an uptrend in living kidney donation again. So total number of transplants are in blue, deceased donors in red, and living donors in gray, going from 99 to 2019. Overall, the kidney transplants have gone up, which is very nice to see. And at the same time, the sort of dip that happened in living kidney donation is disappearing, and you're starting to see an uptrend again. And I know some of this increase in transplant is unfortunately also attributed to the increase in opioid crisis, which has led to an increased number of deceased donor kidney transplants. And then additionally, we're also seeing an increase in paired kidney exchanges. Again, around 2008, the National Kidney Registry was started, and paired kidney exchanges have also taken off, again, because of an improvement in immunosuppression. Donors and recipients don't need to be genetically related anymore. So this paired kidney exchange increase is very heartening to see that more and more of our patients are getting transplanted, even if they don't have an exact match. So what are some of the donor risks and some of the challenges that we face as we try to expand our donor pool, as we try to take care of our living kidney donors? So one of the first big forums in 2004, which happened 50 years after the HERRICK twin surgery for successful living kidney donation, was basically an international forum that brought together from physicians, transplant surgeons from all over the world, and they established a framework and guidelines for standardized evaluation of living kidney donors. And at that point, the thought process was, what is the lifetime risk of end-stage kidney disease for the kidney donor based on their current risk factors? And what we really were looking for was an absence of risk factors in the kidney donor for progression to ESRD. So some of the this is not the entire list of absolute contraindications, but as you can see, some of them were donor hypertension, donor diabetes, BMI more than 35, baseline EGFR less than 80, which would put the kidney donor at risk of kidney disease themselves, and then malignancy, infection, stones, and certain other criteria. But really the goal was to make sure that the donor themselves did not have obvious risk factors for progression to end-stage kidney disease. So now the paradigm has shifted a little bit, and rather than just looking for absence of risk factors, donor evaluation is more nuanced, and it's about determining the individualized risk for each donor based on their demographics and other modifiable and non-modifiable risk factors. You can't really use a set line and put people into black and white categories. Each donor, based on the factors, their genetics, their socioeconomic, environmental factors, have separate risk factors that we need to individualize for them. So KDIGO then came up with this framework for how to analyze or assess the risk of each donor. So every donor comes with some demographic related risk factors, some health characteristics that contribute to their risk factors. It could be the fact that they have high blood pressure or blood pressure that's well controlled. They could be smokers, higher BMI. And then there is a risk of donation itself leading to kidney injury, or donation itself causing them to end up on dialysis. So candidate A would be someone who is probably accepted by all programs. And then there is candidate C, who's probably rejected by all programs, where these are sort of the easy ones that we can understand. But candidate B could be someone, depending on the transplant program's threshold for acceptable post-donation risk. One program may be okay with them after discussing a shared decision-making with the kidney donor, setting up a follow-up and ensuring that they understand their risks, known and unknown, whereas another program may reject that donor. So there is definitely a gray area where we are trying to navigate, and that's where we need more data-driven information, so we're eliminating the guesswork out of it. And again, to talk about how things have changed, this is another proposal that is pending. It's currently available for public comment in the OPTN. But if you look at the first row and the last row, look how we're changing the language, and we're giving each center more room to really assess the donor on an individual basis. So rather than going from active malignancy or incompletely treated malignancy, which laid down the law, we're going to active or incompleted treated malignancy that requires treatment other than surveillance or has more than minimal risk of transmission. So you could consider certain donors, maybe low-grade prostate cancer, and that was completely cured a year ago. So there could be donors whose individual profiles, it might still be okay to go ahead with donation. At the same time, interestingly, even diabetes, which is the last row. So now, instead of just saying diabetes is a contraindication, proposed modification says maybe we should only have type 1 diabetes as a contraindication. And type 2 diabetes should be a contraindication only in individuals in whom an individualized assessment of their demographics or comorbidities reveals evidence of end organ damage or a lifetime risk of complications. So it's possible that with this wiggle room, a much older donor with very well controlled diabetes or pre-diabetes could be considered as a donor by certain programs, again, as a part of shared decision making. So we're sort of moving away from treating donors as black and white, as absolutes, to really looking at each donor and trying to find their individualized long-term risk assessment. So again, even though the cutoff for GFR, for example, is 80, you need to have an estimated or measured GFR more than 80 to be able to qualify for kidney donation. A 22-year-old donor with a GFR of 90 may not be considered a kidney transplant candidate, whereas a 69-year-old donor who is wanting to donate to their spouse with a GFR of 75 may still be considered if their other risk factors are under control. So that line for BMI, hypertension, these are getting blurred, so that we can apply these risk factors to each patient and assess their individual risk. So ultimately, living donation is a balancing act where the benefits on the left, which is for the recipient, much better life, quality, longer life, relief from dialysis, benefit to the donor, which is the psychological benefit from altruism, outweighs significantly the risks to the donor, which should be justifiably low. And risks to the donor are primarily end-stage kidney disease risk or their kidney health risk, surgical risk, financial risk, and psychosocial risk. So I'm just going to focus mainly on the kidney health risk. And that is because the success of living kidney donation really depends on the long-term health of each kidney donor. So this is one of the landmark studies from NEJM in 2009, where it was shown that when you compare donors to controls who come from the general population, the lifespan of kidney donors is actually similar to that of persons who have not donated a kidney. And the risk of end-stage renal disease did not appear to be increased among donors. And their current health in that study seemed to be similar to that of the general population with an excellent quality of life. So this was a very reassuring study looking at retrospective data of almost 3,700 kidney donors, showing that they, compared to general population, they do very well. Interestingly, then we had another study where rather than comparing the donors to general population, they were matched to NHANES non-donor healthy population. And in this sort of retrospective cohort match study, the relative risk of end-stage renal disease was actually higher in the living donors compared to non-donors who were healthy. This study, again, was not perfect. It is retrospective and it's matched to what was thought maybe a very healthy population picked out of NHANES. And the matched population was also from an earlier time cohort. So the thought was maybe since obesity and metabolic syndrome have gone up since that time, maybe comparing an older population to now would have seemed that the non-donors were much healthier than the live donors. But anyway, this sort of gave us an idea that we simply can't ignore the lifetime implications of kidney donation and say that they do just as fine as anybody else who doesn't donate a kidney. So important to note that the absolute risk itself is low. So it's 30 per 10,000 patients who have the incidence of end-stage renal disease in live donors compared to like less than 10 in the non-donors. And interestingly, this also showed a very pronounced effect in Black living kidney donors, which is again a demographic factor that cannot be changed when the donor comes to see you. So the left graph is for Black patients, the blue line showing the incidence of end-stage renal disease per 10,000 in Black living kidney donors was almost 80 compared to non-donors. And you also see that Black non-donors have a higher end-stage renal disease incidence compared to Hispanic and white non-donors. And we'll talk more about that as well. I did include this graph, but also splitting by gender, Black men were at the highest risk for end-stage kidney disease after donation, followed by Black women, then white men and white women. So now we come a full circle. We started off with identical twin surgeries and which started living kidney transplantation because that was the best option for the recipient. Since immunologically it was a great match and it ensured that the recipient got a good kidney. But what about the donor? So now we know that looking back, donor-recipient relationship actually plays a very important role in predicting risk of end-stage kidney disease in the kidney donor. So again, the second column or the second graph is Black patients, about 18,000. And if you see the rightmost graph or the bar is twins, followed by full siblings, followed by offspring. So a twin who donated to his or her twin had a much higher incidence of end-stage kidney disease compared to a full sibling, offspring, or a parent of the recipient. But they all had statistically significant higher incidence of end-stage kidney disease compared to an unrelated donor when the donor and recipient when the donor is Black. Similar effect seen in Asian, where the twin donor had a significantly higher incidence of end-stage kidney disease, but this may be skewed because the number of Asians was much lower in this group, about 4,000. But you can clearly compare the white and Hispanic donors to the Black donors and see that when the Black donor is related to the recipient, the risk of end-stage kidney disease is higher than average. We've also looked at cause-specific risk of end-stage kidney disease. Anjum S. et al. Showed that the first 10 years after donation, if a donor ends up with end-stage kidney disease, the more common cause is glomerulonephritis. But after 10 years, after 20 years, a donor ending up with end-stage kidney disease is more likely due to diabetes and hypertension. So the longer they go from donation, they sort of follow the population pattern and have the more common reasons for end-stage kidney disease, just like we see in the general population. But really to understand the risk of kidney health issues in donors, we have to follow them up for much longer because we could be missing these patients who end up on dialysis a long time after kidney donation. And also the pathways from how these pre-donation metabolic and genetic risk factors contribute to post-donation end-stage kidney disease are still something we are trying to understand. So at this time, in the last 10 years, we've had development of new tools or calculators to see what is the risk for pre-donation end-stage kidney disease, what is the risk of post-donation end-stage kidney disease. So this calculator in the left by Morgan Grams et al. Incorporates many different variables, age, gender, race, GFR at baseline, blood pressure, and then it projects what is the pre-donation end stage. So this doesn't tell us what happens after donation, but it gives at baseline, using the baseline characteristics of the donor, how much are they at risk for end-stage kidney disease 15 years out. The second calculator is from University of Minnesota, again using a lot of variables, but unfortunately they only looked at white donors, so cannot be applicable to everyone. And then this one from Johns Hopkins by Segev et al. Again, uses much fewer variables, so you could still be missing a lot of individual factors. So you can't just go by this calculator because it does not include many of the things that you're capturing in history, physical exam, and labs otherwise when you're trying to assess an individual's risk. So these tools are available, but they have to be incorporated, understanding that they're not the end all, and there's still going to give you an estimate of pre-donation risk and post-donation. Genetic testing is, of course, new as well. And polycystic kidney disease, some of these diseases now, we have whole exome sequencing available, genetic testing available. And I'm just going to focus on ApoL1. Increased risk of hypertension and ESKD in Black donors has been noted compared with matched Black non-donors. And as we saw, the increased risk of end-stage kidney disease is higher among donors biologically related to recipients. And this is thought to be because of the genetic variants in ApoL1, which have been associated with increased susceptibility to non-diabetic CKD in Blacks. So this is autosomal recessive. So you have to have 2 risk alleles to be considered high risk versus 0 or 1 allele. Doshi et al. Showed that ApoL1 high-risk genotype in Black living kidney donors is associated with not only lower pre-donation kidney function, but also post-donation kidney function is lower in these high-risk phenotype donors. And at the same time, looking at this graph on the right, the high-risk ApoL1 genotype, over the years after donation, they have an accelerated loss in GFR compared to the low-risk ApoL1 genotype. In this group, they had 19 patients, 9 who were high risk, and of whom 2 actually ended up on dialysis. So KDIGO actually recommends informing African ancestry donor candidates. Having 2 ApoL1 risk variants increases their lifetime risk of kidney failure. But then we don't actually know what is the precise failure risk for each individual. So we can't really tell them exactly what their individual risk is. So basically, when we feel that the living donor candidate's estimated risk is above the accepted threshold, we can decline the candidate. And when it's below the acceptable threshold, you pursue shared decision making with the patient and proceed with donation based on that. So in summary, living kidney donation has the best long-term outcomes for the thousands of our CKD and ESRD patients currently awaiting kidney transplantation in the face of shortage of organs. So we need to continue to encourage and remove barriers to living donation. And the success of living donation really depends on the long-term health of each kidney donor. We still have a long way to go in developing individualized risk assessments for each kidney donor. And I think an important lesson was that if we had invested in studying outcomes of living kidney donation from the beginning, from 50 years ago, we could have answered more questions today. So I think we need to continue to have a more data-driven approach to really following these donors out and understanding their outcomes over the long term. So quickly going through, I think I'm good on time. The living donor nephrolithiasis, which has been a topic that I've learned a lot about since coming to University of Chicago, where they have a dedicated stone program that evaluates living kidney donors who are at risk or have a history of or have an incidental nephrolithiasis found on imaging. So the current landscape is basically that we are using more and more sensitive methods of imaging, such as CT scan with contrast, and this leads us to find more incidental nephrolithiasis during the evaluation of our living kidney donors. And 3 to 11% is around where we end up finding these in our living kidney donor candidates. Compared to general population, where they have a higher rate of progression to become symptomatic over many years, living kidney donors actually do much better. And they suffer fewer stone events on follow-up compared to general population. But again, we'll talk about how long they have been actually followed up. And also for donor candidates with history of symptomatic kidney stones, there's really no consensus about how long should be the stone-free interval after which it is acceptable for them to donate a kidney. So the increased acceptance of these donors has really stemmed because we have an urgent need for organs, and not because there's any convincing large prospective follow-up study telling us it's safe to do so. So there are some studies that I have listed here where they have followed kidney donors for 2 years, 1 year, and 6 years without significant stone event in the donors. But again, we've really not followed them up much longer beyond this. So similar to any situation, why do we worry about kidney stone risk in the living donor? It's because once they have donated a kidney, they're at risk of obstructing their solitary kidney in the setting of another stone event, leading to a risk of CKD, leading to surgical intervention, or having kidney failure and needing dialysis. So the benefit of going ahead with this, obviously, lots of benefit to the recipient. And like we discussed, psychological benefits to the altruism. And like I'm going to talk about, there is actually benefit to the hypercalciuric donor in that there is a potential risk in stone reduction in stone risk after kidney donation because the decrease in GFR leads to a decrease in hypercalciuria post-donation. We have a number of policies and guidelines by many different bodies that guide us or give us a framework of how to evaluate these donors. Amsterdam Forum set the standard, but they also interestingly say to exclude patients with bilateral kidney stones, but there's actually no data that is referred to really put that forward. So it's not an evidence-based recommendation. So that is something also that I have a slide on later. And all these different bodies broadly agree that a donor at risk of kidney stones should get 24-hour urine metabolic profile checked. And but then after that, how to interpret it and how to evaluate the donor and determine the risk is sort of left to each transplant center. So this leads to a lot of variation. So every program is probably going to do the 24-hour urine, but then based on that, one center may accept them and another center may actually reject them because the interpretation of these tests has not really been standardized. So I'm going to briefly touch upon how the approach has been here at University of Chicago. So I went back to 2014 and from 2014 to 2021 looked at what have we been actually doing with our living kidney donor candidates by sending them to the STONE program. So I found 40 patients, of whom 31 had incidental nephrolithiasis and 7 had symptomatic stones. So our program has a policy of excluding bilateral kidney stones based on the Amsterdam Forum. So 8 patients were automatically excluded. And then we also had a couple of miscellaneous patients, 2 with nephrocalcinosis, 1 patient who had a history of bariatric surgery, which put them at risk of oxalate stones. These patients otherwise had not formed a stone. And without any other obvious reasons for declining them, they proceeded with a stone evaluation. So they get referred to our stone clinic where Dr. Anna Zussman sees them. So we have them do a 24-hour urine collection ×2. At this point, again, we have some attrition. Some patients are lost to follow up. They're not motivated or they're unable to follow through with these instructions. And then some get declined due to other reasons that are uncovered by them. So of these 24 patients who eventually made it through the first visit with the stone specialist, 10 of them actually had pretty good urine metabolic parameters. 3 had completely normal ones, so they just were accepted immediately. And then 7 actually had some abnormalities, which didn't need them to come back to the stone specialist, but they were given counseling so they understand what their findings were and what they need to modify in their diet and lifestyle. And then nobody was actually declined in the first evaluation. So everyone got a conditional acceptance pending an intervention. And then intervention, whichever patients were successful showed an improvement in the urine metabolic parameters, were then accepted from a stone risk perspective. And only 2 patients got declined in the end because their intervention was not successful. And then again, attrition at every level. Some patients just did not follow up, and then we found other reasons because of which they were declined. So the first 10 living kidney donors that I showed who were cleared at the first visit. There were 6 males, 4 females. Three of them had symptom history, 2 years, 10 years, and 16 years prior was their last stone event. 6 patients had a punctate single stone. 1 patient had a 3 millimeter single stone, and all these stones were in the interpolar, midpole, papillary area. So apart from a few outliers, majority of them on average, they had excellent urine volume, did not have high supersaturations for calcium oxalate, phosphate, or uric acid. And apart from minor modifications, for 7 of these patients, they went on to get cleared from a stone risk perspective. So then I'm giving an example of patient A who was actually cleared after they underwent an intervention. So 54-year-old female had a history of stone event 8 years prior on the left kidney. And then when at the time of living kidney donation evaluation on the CT scan, she had a 2 millimeter incidental stone in the same kidney. So in the first visit, she was noted to have hypercalciuria and also a degree of hyperoxaluria. And intervention that she underwent was, and also high sodium. So she was counseled on by a dedicated dietitian on low sodium, low oxalate diet, started on a thiazide, and she showed an improvement in her parameters. And then interestingly, 6 months post-donation, her hypercalciuria improved even further, showing that donation actually may benefit a donor who has hypercalciuria at baseline. So this decreased her risk of kidney stone formation in the future even more. And we have another very motivated patient who wanted to donate to his wife, 53-year-old male, punctate stone in left kidney, BMI on the higher side, pre-diabetic, noted to have a higher supersaturation for calcium oxalate, hypercalciuria, and hypernatriuria. So he was advised to increase fluid intake, increase his vegetable and fruit intake, decrease animal protein intake. Potassium citrate was started for urinary alkalinization with a pH of 5.3, and he was advised to decrease sodium intake. So he comes back after the first intervention, and I'm so sorry. So he comes back after the first intervention, and his numbers actually look worse. So he undergoes a second round of counseling with the dietitian again to increase his fluid intake further, decrease his salt intake. And you can see that he's trying. His fluid intake is going up, but he's not able to successfully stick with the dietary interventions. So his supersaturation remains high. And strangely, whatever dietary changes he made, his hyperoxaluria actually got worse. And this is a very motivated patient who's done multiple urinary collections, been back to the stone clinic, who really wants to donate, but unfortunately had to be declined because of these lack of improvement in his metabolic parameters. And then this was a patient who sort of first went to stone clinic and then came to transplant center. So he is 47-year-old, wants to donate to his elderly mother. So she is in her 70s, and if she doesn't get a living kidney donation, she's probably going to not be a candidate waiting in the list for 5 years. So he has a very strong reason to be very motivated to donate to his mother. So he had a history of stone event 9 years ago, bilateral stones, 3 punctate stones on the left and 2 on the right that are shown in the imaging here. And he gets rejected by 1 transplant center. So he comes to our stone program, and so these are individual collections that he has done, and he has absolutely no abnormalities. And on further history taking, going into his health, 9 years ago, the events in his life were different. He was under stress in a very busy job, not drinking enough fluids. And after that, he's significantly changed his lifestyle. I mean, his urine volumes at baseline are excellent, 2.5 liters, 3 liters, 3.5 liters. And he clearly has no other metabolic risk factors that put him at risk for future stone events. But when he got referred to our transplant center, he again got declined because our policy was to decline patients with bilateral kidney stones. So some of the lessons I learned looking back at how we do stone evaluations for our living kidney donors, there's definitely a need for consensus and evidence-based guidelines in selecting living kidney donor candidates who are at risk or who have nephrolithiasis. I learned that isolated low urine volumes, hypercalciuria, hyperoxaluria to a degree are actually not absolute contraindications to donation. In fact, hypercalciuria actually improves after donor nephrectomy. And possibly candidates with bilateral nephrolithiasis on imaging may proceed to kidney donation after careful evaluation, of course, with very good establishment of a robust follow-up for these patients since they are at high risk. And the other sort of benefit of doing a 24-hour urine metabolic panel on a kidney donor, regardless of stone risk, maybe we discover hyperoxaluria, we discover hypernatriuria, and these could portend to future post-donation development of metabolic syndrome or hypertension. And this would give us another opportunity to counsel our donors to modify their diet and lifestyle to minimize the risk of future kidney disease. With that, I thank you so much. So thanks to also Dr. Zisman, who has done all of this work and that she's letting me share working with her, and Dr. Josephson, Chapman, and Dr. Koh, who have been helping me learn more about living donor evaluation with nephrolithiasis. And that's my residency class photo with Dr. Casper.
Thanks so much, Sam. That was a great talk. I don't know, how do you want to do questions, Jason? Tell me what's going on.
Folks can either you can unmute and ask a question, or if you want, you can type it in the chat area. And I was going to see if actually going to see Dr. Usef if you had anything you would like to start off with.
Hey, Sam, do you have any idea how long they wait in Stone Clinic after they do an intervention? Is it like they have them come back in a month, or is there something?
In a month, usually. Yeah.
Because you have this like small period of time where you have all your cardiac testing up to date and everything up to date, and then so what all things do you not do any of the other evaluations for the stone?
We usually, I think, leave the stone for the last because it's painful to do those collections. So if it's a young Black donor and the ApoL1 is going to change things for them, we would wait for that before. I mean, we would get an appointment and be ready, but we would probably leave the stone evaluation for last when we have sort of other issues that we think are borderline. But if they have a significant history, rather than just a punctate incidental nephrolithiasis, if they have a longer history or a longer course, then if that's going to be a major deciding factor, then they end up going first to the stone clinic.
Gotcha. And if I can ask another question, what do you guys do for African Americans who are older, who have maybe hypertension plus minus ApoL1? Like, so now the whole thing is about, well, if you're 60, 65, your risk for kidney disease should be lower, but now you have a little bit of hypertension, and then does it change your idea whether they have ApoL1 or not?
So I think it for older patients, we don't take the ApoL1 into account as much.
Okay.
So I would, if they're in their 60s and they have one or two risk factors, so I mean, obviously, if they have multiple things going on apart from the hypertension, we may worry. But if that's the only thing, then I think we might still go. We will still be okay for an older donor. Is how.
Is there data about hypertension in African American donors? I mean, because the original data was definitely, I think, Caucasians, one blood pressure pill, controlled.
I would have to actually get back to you on that. I don't remember exactly based on which study or what was the exact reference where. So this was from like an editorial, Doshi et al. That they had mentioned that there is an increased risk of hypertension in Black donors. But I didn't see if it was older or younger or which exact paper they were referring to.
Gotcha. Because obviously that's like one of those in between, one of your in between bars, right? That's the harder things to think through when you're looking at donors.
Yes.
All right, Dr. Krishnamoorthy. Actually, I have a question from Dr. Casper. It's in the chat area. She put, excellent talk, Sam. Can you comment on the cost to the donor? Does insurance cover the surgery and recovery? And also, could you comment on kidney donor chains? How common is this?
Cost to the donor for evaluation and surgery are actually covered by the recipient insurance. So as long as the recipient has insurance, the donor can move forward. But the issue is also whether we still want our donors to have insurance in our program before we approve them, because after donation, they could still run into issues, which then won't be covered. So it's still important that they have health insurance. And then kidney donor chains are becoming more common for sure. I don't know, maybe others who have more experience may be able to give the exact percent breakdown of how many. But recently, National Kidney Registry sent out like their annual report, and they've done like 40% more chain donations via like their paired exchange program and chains compared to last year. So it's definitely an option that we have been using more and more and are getting more comfortable with. So the numbers are definitely going up for that.
All right. Kim Rowles, who's the Executive Director of Transplant for UofL Health and Jewish, I think she has a question.
Hi, good morning. Can you hear me okay?
Yes.
Great. Thank you. Excellent talk. I completely echo many of the administrative non-clinical points that you made today. Certainly, I think nationally, it is undisputed what the benefits are of live donation versus deceased donation in terms of post-transplant outcomes. And I agree with you that nationally, I think we're doing a lot regarding policy to try and increase deceased donors. I apologize, my camera's not working. However, the real opportunity for growth is by far in live donation and pardon me, potentially some of the xenotransplantation that is really emerging again, as you mentioned. So excellent talk. I'm curious about at your center, what you specifically do if there, and maybe part of this talk, or I'd be happy to, take this offline with you, what you specifically do to promote a culture of live donation. Because I think, everybody that walks in, I think we all collectively feel like, hey, somebody knows somebody that wouldn't it be great if people walked in and we did a better job as transplant professionals to encourage potential recipients to find donors. But we also know it's hard for people to ask for something for themselves. And so I'm just really curious if you can share some of the tactics, techniques, best practices that you do to really promote live donation as a culture with your patient population. So can you speak to that?
Yeah, thank you. That's a great question. I do have a disclaimer that I've been doing this for a little more than a year. So there are others who have a lot more experience with this. But I think, so our patient population is South Chicago, predominantly Black, and we have data showing that Black patients tend to have a higher proportion of related, the donor and the recipient being related compared to unrelated donations in white population. And also because of now having APOL1 testing, potentially knowing the risk factors of a Black donor, there is also a risk that they are now disadvantaged because we might say no to their donor. So these are some of the issues that we're dealing with, especially if there's a family history of end-stage kidney disease. So to promote a culture, I think, again, having a dedicated sort of living donor program where you are trying to consciously push for more living donations and educating your transplant team. But I think educating the referral base is even more important, because if you really want to increase preemptive living kidney donation, then it is the general nephrologist who is seeing a CKD4, CKD5 patient, where you have to really start educating the patient and planting the idea in their head that living kidney donation would really change the game for them, would really change their long-term outcome. So I think it's not just the transplant program, but making sure that the general nephrology program, the fellows who are training with you, the nurses who are working with you, that everybody understands the importance of living kidney donation and the importance of preemptive living kidney donation that ties this up together. There are different programs that you could try. I think Harvey Meisel has a How to Find Your Living Donor program that we tried to do briefly, which, again, depending on your population, we didn't have a great uptake on that program, but there are resources available. And, our coordinators really push for living kidney donation in every visit. And sometimes we also have, after the pre-transplant evaluation, we go back and have a video visit with the patient specifically to discuss living kidney donation with certain patients to encourage them to look for donors. But again, you're right that it has to be a push at the program level, but it has to go down to every level, including outside the program, for educating the dialysis technicians in the dialysis units nearby who are referring your patients to you. That is another approach as well that helps. Sort of, these are the people the dialysis patients see every day, and hearing it from them makes a big difference as well.
Yeah, if I can just follow up on that comment, and based on the last question, I completely agree with you about education being a key component to this culture. And you're right, gone are the days where you have to, quote unquote, be a match, right? I think there's still enough misinformation in our community that somebody has to be a match. And you're absolutely correct.
That's a great point.
Being paired and chained. And that's one of the considerations that we're really thinking about here at our center too, of how do we really promote live donation? And if somebody shows up and they're not a match, maybe they're willing to be an altruistic donor. Maybe they're willing to be a chain starter or something like that. So thank you so much for the presentation today, and thank you for your thoughts on this culture.
Thank you so much.
Hi, Dr. Krishnamoorthy. Thank you for your talk. This is Hitarsh Dave. I'm one of the transplant nephrologists in the program. I have a couple of questions for you. One, you mentioned that most of the recipient insurance would have donor benefits. What does your program do if the recipient's insurance, is not going to cover donor evaluation?
They don't transplant either.
Yeah. I mean, they have to be in network with the transplant center, and I don't think such a situation has ever arisen, or they would have to change because the finance is always the first thing that they go through, right? Yeah. So I think those patients are probably caught at that point, so they never make it to our end.
So if the recipient's insurance does not have donor benefits, you don't move forward for.
Yeah, but we do have. So this is an area that I don't know much about. Is recently we've had an international program start where we do have patients from not many, like 2 or 3 coming from outside US. And I am actually not sure how they are being processed or how their insurance is being processed, but I'm presuming they are probably paying out of pocket. So
the other question is, so SRTR is starting this Living Donor Collective. Is your program a part or thinking about getting involved?
I will have to get back to you on that. I am not sure. Yeah.
Okay.
Yeah.
All right. Thank you. Thanks.
Thank you. Nice to meet you.
Yeah, same here.
All right. I don't know if anyone has any more questions. Our time's getting a little short here, but just real quick, Dr. Krishnasamy in endocrinology wanted me to say hello to you for you.
Hi,
She
Dr.
said,
Krishnasamy.
yeah, and she said had in the chat said a great overview, wonderful for you to work with Fred Coe, who is a pioneer in the stone field.
Thank you so much. It's great to hear from you.
And I believe Dr. Kubiak is here. I don't know if she wanted to say hi real quick or. She may have stepped away. So, but anyway, Dr. Youssef, do you have anything? I think we can go ahead and kind of start wrapping up. Do you have any last comments before we take off here?
Oh no, but Sam, that was great, great, great. Thank you so much for talking today.
Thank you so much for having me here, Dr. Youssef. And Dr. Kubiak just said hi. Hi, Dr. Kubiak.
And
So good to see you again, Sam. This is Barb Casper. So
Same here, Dr. Casper. Please take care.
yeah.
And before you go, I don't know if we had started this or not, but Dr. Roman had started a tradition for our guest speakers for Grand Rounds to give them a little gift, little something that is familiar with the city of Louisville. You've probably seen this, so you are going to get your very own Louisville Slugger bat.
Oh my God, that's awesome. I actually don't have one, so that's awesome.
Yeah. So congratulations, and I'll get in touch with you about where to ship it and sending and everything. So
Awesome. Thank you so much, Jason.
Thank you, and thank you for an outstanding presentation, and especially with the it's definitely timely and very pertinent at this time, and we really do appreciate it. And thank you to Dr. Youssef for facilitating, and Dr. Breyer. We really appreciate you guys getting us in touch again with Dr. Krishnamoorthy, and we're glad to see her again.
Bye, Sam. Have a good day.
Bye. Take care.
Right,
everyone stay safe. Bye. Bye.
You too. Thank you. And everybody, just don't forget, we will be back next week, February 10th. Infectious diseases will be presenting next week, so the same time, 8 a.m. next Thursday. So we'll see you then. So thank you again, everybody. We really appreciate it.